Hi guys, today we are going to be talking about the basics of asthma management in kids, and this presentation is going to cover just an overview of the main points which a pediatrician should be knowing about asthma. We're going to have some information about principles of management as well as trigger recognition, exposure control, and the medications as well as the treatment plan. So depending on how long the video goes, I may split it into half and discuss the medications and treatment in another video. So the core concepts in asthma management are trigger reduction, education, pharmacologic treatment, and follow-up. So both the medications and the lifestyle management are hand in hand, with particular emphasis on the first 2 points which I've mentioned, which are trigger reduction and education. So the end goals of asthma treatment are to reduce disease symptoms, decrease the exacerbations, and to minimize medication side effects. So our goal is that a person with well-controlled asthma should be able to participate in work, school, play, and sports without any limitations due to breathing. So we want to enable a person with asthma to be well enough to participate in society just like the rest of the people. So let's start off with the core point, which is trigger management. So this is a short exercise. You can pause the video here and try to identify 7 triggers in this picture. So we have some of the most common asthma triggers like animal dander, viral infections, mold, tobacco smoke, dust mites, wood smoke, and cockroach allergens. So how do we reduce exposure to triggers? For viral URTI, the simplest is to avoid contact with them. And if the child is part of a daycare, try to choose one with fewer children for sake of infection reduction. And annual influenza immunization is recommended, especially for those with persistent asthma. No smoking in the house, and you will try to help the parents or caregivers quit smoking and try to eliminate wooden stoves and fireplaces within the house. As for hygiene, do not leave food or garbage exposed in the household area. Try to control the cockroach issues and reduce the indoor humidity to less than 50%, as well as avoiding vaporizers and fixing leaky faucets and pipes because that is the one of the sources for mold. So this is a picture kind of summary of what I've mentioned. So it's important to try to reduce the humidity inside the room. So a vaporizer is not a good idea, but a dehumidifier will again have a more positive impact. How about dust mite exposure? So this is something which parents will ask very commonly, and there we kind of study that you have to reduce the dust mite exposure, but maybe we don't really know how exactly it's done in practical life. So the essential action here is to encase the pillow, mattress, and box spring in an allergen impermeable encasement, and we will see in the coming slide what that exactly means, and to wash bedding in hot water weekly because germs actually build up in the bed sheets, and that can again trigger an exacerbation. Some desirable actions would be to avoid sleeping or lying on upholstered furniture, which is basically furniture that has a soft padded covering, and we'll be seeing pictures as well. Reduce the number of stuffed toys in the child's bedroom. A lot of kids' beds are full of stuffed toys, and that actually traps a lot of dust and germs, and this can create issues. Reduce the indoor humidity as we mentioned, and if possible try to remove carpets and carpets from the child's bedroom because that can build up dust as well. And if it's not feasible, try to vacuum it frequently. So what does the word hypoallergenic mean? We know that hypoallergenic is kind of self-explanatory. Has less chance of triggering allergies, but how exactly does it work? So the fabric is tightly woven and it's made up of a certain material which is less likely to retain indoor allergen particles. So it kind of creates a barrier between the skin and the bedding surface. And these hypoallergenic fabrics are breathable and they promote a cool environment in which mold and bacteria cannot grow, as opposed to a very hot or humid room. Usually, they are made up of natural fabrics such as cotton, bamboo, silk, and eucalyptus. And those are, from the natural fibers. But if you're using a synthetic fabric to create a hypoallergenic material, then there is just a slightly higher risk that they could irritate the skin and they will not be as breathable as the natural fabric. So this is what it looks like. You can see the pillow cover, you can see the mattress cover. It's gets basically encased upon wherever the child will be lying. And this is what upholstered furniture looks like. So this will basically hold on to a lot of dust and germs. So it's not recommended for the child to be staying in that kind of, a prolonged period of time on that kind of furniture. How about animal dander exposure? So try to remove the pet from the home if the child is getting triggered by their dander, or keep the pet outside. Uh, if neither of those are possible, then definitely keep it outside of the child's bedroom. And there are certain filters which can be put on the air ducts. So this will also prevent, reduce the amount of dust coming in from the air vents. Let's move on to medications now. For medications, there are two types that we should be knowing about: controllers and relievers. So, in the controllers category, we have four medications: inhaled corticosteroids, leukotriene modifiers, long acting beta 2 agonist, and omalizumab. And in the relievers, we have the short acting beta 2 agonist, anticholinergic agents, and oral corticosteroids. So, what is a controller? A controller controls the asthma. A reliever aborts the acute exacerbation. So both are important to know about. Let's start off with inhaled corticosteroids. Inhaled corticosteroids are the most effective anti-inflammatory medications for chronic persistent asthma, and they are the preferred therapy when initiating long-term control therapy. As we will see in the final part of the presentation, when we are following the stepwise approach, once the child requires a controller therapy, the first one that we start is most commonly inhaled corticosteroids. So early intervention with ICS will reduce the morbidity but doesn't alter the natural history of asthma. So obviously it is not the cure for asthma, but it is a very good controller medication. How does it work? It will reduce the airway hyperreactivity. It will decrease the need for rescue bronchodilator therapy, decrease the hospitalization, and decrease the death from asthma. And an important point is that you are assessing the effectiveness of the controller medication by the amount of rescue therapy that the child needs. So, if a child is requiring Ventolin or salbutamol inhaler usage multiple times in the day, every day, or most of the days in the week, it's a sign that the controller medicine is not working properly, or it's not being used enough or properly by the child. So, it's an indication that um, the controller is the controller therapy needs to be modified. Some of the common side effects of ICS are dysphonia, oral candidiasis, and decreased growth velocity around 1 centimeter in the first year of treatment, but this is non-progressive and it's reversible. And as you can see in this balance on the side, if you have a child with very poorly controlled asthma, that itself will impair his growth and height increase. So you have to weigh it against the ICS side effect, which is very, I would say the first two, the dysphonia and oral candidiasis, are far more common. And the best way to avoid the first two side effects is to rinse the mouth after the use of a steroid inhaler. A low to medium dose ICS will not cause disturbance of the hypothalamic pituitary axis or glucose metabolism. It does not cause cataract and it does not cause glaucoma. So most of the parents will approach you with these concerns that they have heard that steroids can cause sugar problems, it can cause eye problems. So you can reassure them that if the child is using a low to medium dose, we will not be expecting these side effects as opposed to the more common local side effects of the mouth and the throat. This is what an inhaled corticosteroid looks like. They are usually orange in color, and these are the common names. Where I have practiced, Pulmicort or budesonide is the most common, and Flixotide as well is commonly used. So the orange inhaler will control the sickness. This is just a way to remember. And of course, check back into your hospital's practice to know what your local inhaler looks like. But almost universally, the inhaled corticosteroid inhaler is orange. Let's come to the leukotriene receptor antagonist. So, what is a leukotriene? Just as a quick recap. So, leukotrienes are mediators of inflammation and smooth muscle bronchoconstriction that are present in our body. So, a leukotriene modulator or modifier is an oral medication that will inhibit the effects of these leukotrienes in the airway. So we have two types. We have the receptor antagonist and we have the synthesis inhibitors. So what I have seen far more commonly used is the receptor antagonist, especially montelukast. So this is an oral medication and it comes in a granular form. Some of the common side effects are neuropsychiatric disturbances, and unfortunately, it has been reported in several children, making it a black box warning. So it can kind of make the child look like they're having ADHD or some other kind of neurologic disturbance. And xylitol is known to cause deranged liver function test as well. How do we administer montelukast? It is supposed to be put directly onto the child's tongue or put onto a certain kind of food like yogurt or ice cream, and the child should take the dose within 15 minutes. But you cannot dissolve these granules in a drink just because of the way that this medication has been formulated. Let's look over some other controller medications. As we mentioned, LABA, which are the long-acting beta agonist, and we have omalizumab. So the long-acting will cause smooth airway relaxation for 12 hours, but it's critical to remember that you should not be using LABA without an inhaled corticosteroid because it can trigger a life-threatening asthma attack. So this is very important for both exam point of view and also for real clinical practice point of view. So, and it's seen now in clinical practice that they are not even producing lava on its own anymore. You usually in the market have a combination of salmeterol plus fluticasone. So salmeterol is an example of a lava, and you will rarely find it on its own. It will be given as a preparation together because of this very important point which is in red on the screen. Omalizumab is a humanized anti-IgE monoclonal antibody, and we know that IgE is involved in the allergic response in the body. So it prevents the binding of IgE to the receptors on basophils and mast cells, and it's usually given subcutaneously every 2 to 4 weeks. Now, this is an interesting point in which we learn that chronic use of LABAs will cause tolerance due to downregulation of the beta 2 adrenoreceptors. So, this is associated with an increased risk of mortality in patients with asthma, and this is the reason why the use of LABA alone is contraindicated. So, I used to have trouble remembering this important point, but once you kind of understand the background, you will be able to retain this information better. And the downregulation of beta 2 adrenoceptors by chronic use of LABA will impair the body's response to SABAs when they are needed for acute relief of symptoms during an asthma attack. So this creates a very dangerous situation. Basically, you are giving a medicine that is causing down regulation of the receptors, and you are preventing the reliever medication from working at the very acute stage. So how does the inhaled corticosteroid addition help? It will control the inflammatory process of the underlying asthma, and they also upregulate the beta 2 adrenoreceptor expression. So when you combine both of them, it balances out. So that's why again LABAs are only used with corticosteroids. Now coming to the reliever medications. So we have three main reliever medicines, including the short-acting beta-2 agonists, which are used to relax the bronchial smooth muscles. The effect is within 5 to 10 minutes and they last for around 4 to 6 hours. Some common side effects include tremor, tachycardia, irritability, and the most common example of this medicine is albuterol. We have anticholinergics, which both cause bronchodilation, but they also decrease the mucus secretion and counteracts the cough receptor irritability. So it's good for a patient who's having wheezing and a lot of secretions as well. And the common example is ipratropium bromide. Then we have oral steroids, which again cause bronchodilation and reduce the mucosal edema and mucus secretion. The most common example is prednisolone. So oral steroids will not have an immediate effect like the SABA and the anticholinergics do. However, they are used during an acute exacerbation as opposed to the inhaled corticosteroid, which was used for the controller as a controller medication. Coming to the treatment plan, we have the stepwise approach. Now, this is extremely important to know, and it comes in most exams. So, they will ask you how the patient's care can be upgraded. Let's start with the 0 to 4 years old row, in which we can see that the first step is usually the SABA as needed. Then you will add on low dose inhaled corticosteroid if patient is not responding, followed by increasing the dose of the inhaled corticosteroid. If the patient is still not responding, you will add on the LABA or the leukotriene receptor antagonist. Further, if there is no response, you will move towards the high dose. And then if there is no response at the end, you will further add on the oral corticosteroid, or in older children, you can even consider the omalizumab, as you can see in the age of older than 12 years old. Thank you so much for watching, guys. Hope that you learned something from the video, and please stay tuned for the next part, in which we will be having a more practical approach to managing an asthma exacerbation in the emergency department. Thank you so much.